I think we can go ahead and start.
Yeah. Yes, sir. Yes, sir. Okay. Yes, sir.
9 o'clock, you can start.
Okay, sir. So, good evening and welcome all of you in this fourth session of IAP NRC General Club. And today with us, Dr. Bafna sir, our treasurer, our Indu Khosla ma'am, our coordinator, and Dr. Joseph sir, our national expert. And I also welcome our session expert, Dr. Rakesh Lodha, sir. All of us know Dr. Lodha, sir. He is professor and in charge pediatric intensive care, New Delhi. As his special area of interest is in pediatric intensive care, pediatric respiratory disease, and infectious disease. I also welcome Dr. Parmat Chandane, sir, the session expert. And he is, as per information, HOD Pediatric Pulmonology in the Vijayawada Children's Hospital. Welcome, sir. And I also welcome Vishal Samaga, our presenter. He is IPNRC fellow in the Vijayawada Children's Hospital. I also welcome all our EB members like Santanu Dev sir, Kasi Bandaru, Dr. Hajarika, and all EB members. So I now hand over the session to Dr. Indu Khosla ma'am for coordinating the session. Madam, please.
Thank you, Dr. Ajay Kumar, and I welcome all of you for one more enlightening session of this journal club. And today the topic is efficacy and use of azithromycin for a condition called as primary ciliary dyskinesia. We know primary ciliary dyskinesia is one of the orphan diseases, I would say, because there is a lot of, I think, controversy right from the word go of diagnosis of PCD, whether it is the European Respiratory Society versus the American Thoracic Society, where the thought processes are a little different. And of course, there is a lot of overlap from primary to secondary ciliary dyskinesia. There's also a variability in the phenotypes of PCD, making this a really difficult disease to diagnose and treat. We extrapolate a lot of data on PCD from cystic fibrosis, and the most important thing that we tend to extrapolate is use of azithromycin for prevention of exacerbations. So this article from the Lancet is one of the few pioneering studies which is looking at use of azithromycin for prevention of exacerbation in PCD. Let's look into this, deep dive into this study with Vishal's presentation. And then, of course, we will look at because it's a very important step in the management of a disease like PCD, and where many of us are, I would say, using this molecule even without having much justification or much data to back us up. So after this study, we will first analyze the depth of this study, and then maybe we would also end up by giving a small message whether this drug can be used for preventing exacerbations for PCD. Over to you, Dr. Vishal. Looking forward to your presentation.
Vishal, unmute yourself.
Am I audible now, sir?
Yeah.
Is it visible, sir?
Yes, please go ahead.
Okay. Good evening. I'm Dr. Vishal from Vijayawada Hospital for Children from Mumbai. I'm a first year pediatric pulmonology fellow. So today I'll be presenting the journal from the Lancet Respiratory Medicine, which is efficacy and safety of azithromycin maintenance therapy in primary ciliary dyskinesia. The trial was called the BEST CELIA trial. It is a multi-center, double-blinded, randomized, placebo-controlled phase 3 trial. So my mentor is Dr. Parmat sir, who is our head of pediatric pulmonology department. So just to give you an overview of the things we'll be discussing today, firstly, it will be the journal article discussion per se, followed by a critical analysis of the article, followed by a conclusion. Coming to the introduction, so primary ciliary dyskinesia is a rare genetically and clinically heterogeneous disease which manifests from neonatal period all the way progressing through adulthood. So primary ciliary dyskinesia is primarily because of an impaired mucociliary clearance, which is due to abnormal ciliary beating, which causes an excessive accumulation of mucus and bacteria in the airways. So this in turn which leads to recurrent LRTIs, which usually lead to bronchiectasis and a decline in lung function. So PCD is basically a suppurative disease, which is characterized by the following manifestations. One, upper airway, it can be seen as a chronic rhinosinusitis or a recurrent otitis media with conductive hearing impairment, as well as in the lower airways can be seen manifesting with chronic productive cough and LRTIs. So there are currently no drugs which have been developed for the treatment of PCD. It has been difficult to develop evidence-based guidelines for treatment because of a paucity of clinical studies and the lack of scientific evidence for effective treatments. And these guidelines are urgently needed because the prevalence of PCD or the diagnosis of PCD is increasing, and with the increasing diagnosis, there's also a need to reduce the morbidity of the disease and its impact on the quality of life. So this study is important because maintenance therapy with macrolide antibiotics such as azithromycin has been evaluated in several other chronic respiratory disorders following the evidence of the effectiveness of long-term treatment with erythromycin in diffuse PAM bronchiolitis. So azithromycin is basically bacteriostatic, has anti-inflammatory effects and properties regarding quorum sensing inhibition. So quorum sensing inhibition is basically when two bacterial cells interact in order to form a biofilm and basically increase their pathogenicity. So azithromycin has a very important quorum sensing inhibition effect. So this trial is also called as the BEST Cilia trial, which is the Better Experimental Screening and Treatment for Primary Ciliary Dyskinesia trial, aimed to determine the efficacy and safety of azithromycin maintenance therapy in patients with PCD. So coming to the inclusion criteria for this trial, so according to the authors, they presumed a confirmed diagnosis of PCD, which was added in their appendix, which include one is the clinical symptoms and signs like previously mentioned of PCD. Along with this, they also other screening tools such as nasal nitric oxide, a positive value less than 77, or along with this, a positive genetic mutation, which has a pathogenic variant of PCD. These were included in the confirmed diagnosis of PCD. Secondly, the age which they took was 7 to 50 years. Initially, it was 7 to 40 years, but because their recruitment was not completed, they extended the age to 50 years. And also the age was slightly, the range of age included was wide, predominantly because of the prevalence and the rarity of the disease. Third is that the predicted FEV1 at inclusion was greater than 40%. Then fourthly, the child should have at least received 30 days of antibiotics prescribed for respiratory tract infections or exacerbations within the past preceding 2 years, which is likely suggestive that the child has had exacerbations or recurrent infections in the past 2 years, which is requiring antibiotics for the treatment. And currently, the child should have been receiving no systemic or any inhaled maintenance antibiotics. And finally, the child should not have had taken azithromycin within 1 month prior to screening. One second. Coming to the exclusion criteria, They excluded those which were involved in reducing the long-term lung function, such as Achromobacter xylose oxidans, Burkholderia capacia, as well as excluded children who have acquired non-tuberculous mycobacteria within 6 months or chronic infection with Pseudomonas aeruginosa. These all likely could impact the long-term lung function. Secondly, they excluded those who were allergic to the particular antibiotic, azithromycin, followed also those who were having a baseline ALT, which was 2 times the upper limit of normal or a history of portal hypertension, those who had elevated serum creatinine. Along with this, they also excluded those with other related drug-related side effects at baseline, such as prolonged QT interval, cardiac arrhythmias, severe heart failures, electrolyte disturbances, myasthenia gravis. And for older and female patients, they excluded those who are pregnant, breastfeeding, or using unreliable contraception, and also excluded those who were using home oxygen or assisted ventilation. Coming to the methods, basically the study design, firstly, it was a multi-center trial. Multi-center trial involving six centers. First was in the Netherlands, Amsterdam, followed along with this Switzerland, Denmark, Germany, and 2 centers in the United Kingdom at London and Southampton. So along with this, they have mentioned the trial is double-blinded, though that the blinding done was more comprehensive in the way that the patient, the caregiver, that is the healthcare provider, as well as the investigator, were all blinded. So though it has been mentioned as double-blinded, it is more comprehensively blinded. Thirdly, it was a parallel group study where there were 2 limbs, azithromycin limb and a placebo limb, and both were treated parallelly. And it is a randomized controlled trial, which is placebo controlled, where one of the limbs was a placebo controlled trial. And it was a phase 3 trial where they were assessing also for the adverse effects of azithromycin on a larger basis. So participants were randomly assigned to azithromycin or placebo group, and they were stratified by age. 3 stratification groups were made: 7 to 12 years, 13 to 21, and 20 to 50 years. And the study sites. So regarding the study sites, they were merged into 3. That is, the Bern, Amsterdam, and Southampton were merged because of the recruitment, as well as to maintain to keep the stratification purpose, to make sure there's overall balance between the 3 groups. So along with this, the random allocation sequence was a block randomization in this study. A block of 4 was used, which had been generated by an external consultancy. So randomization was done by an external consultancy using a web-based data and randomization system. So this was the method of randomization used in this study. So along with this blinding, there was blinded packaging and labeling of the study drugs was done centrally at the hospital pharmacy before delivery to the study sites. The participants, investigators, study personnel, as well as the caregivers were all masked to treatment allocation until after the end of the trial. So following randomization, the procedure was the oral tablets of azithromycin, or 2 doses, 250 mg and 500 mg, according to body weight, that is less than or greater than 40 kgs, or identical placebos were self-administered 3 times a week. Based on the weight, the dose was given, and the doses were given on Monday, Wednesday, and Friday for 6 months. So a pre-study medication continued unchanged except for maintenance antibiotics and certain prohibited medications. So there was no maintenance antibiotics other than azithromycin given, and those interacting with azithromycin were also avoided. So additional antibiotic treatment was allowed only during clinical exacerbations and in cases where infection with Pseudomonas aeruginosa and the other organisms mentioned emerged during the study. Other than this, other antibiotics were avoided. So the patients were initially screened for eligibility, that is the inclusion and exclusion criteria. Following this, they were randomized in a stable state. Following this, they were screened using baseline tests like spirometry, ECG, sputum analysis. After this, there was a 1-month run-in period. Why this run-in period was set was so that it to ensure that there was stable lung function, and the lung function is stable in that the FEV1 was not dropping beyond 10% from the time of screening to the time of randomization, and there was any washout of any prohibited medications. So study visits were scheduled every second month during the treatment period. So the study visits were done at 2, 4, and 6 months. So patients were instructed to contact the study sites in between their scheduled study visits if they had any symptoms of exacerbation. And meanwhile, they were asked to complete a weekly diary card of symptoms and antibiotic use. So patients were withdrawn from the study if they received antibiotics to treat an exacerbation or infection for more than 14 days during the run-in period. So up to 14 days was allowed. Greater than 14 days, they were withdrawn from the study. So all the study visits at year 2, 4, and 6 months included assessments of firstly symptoms of exacerbation, secondly adverse events and concomitant medications, thirdly just physical examination, fourth was the completion of PCD quality of life questionnaire. Fifth was a nitrogen multiple breath washout test, and followed by sixth was spirometry and a blood body plethysmography. And finally, a sputum culture, and in those who were fertile, a UPT as in a fertile woman. So additionally, there were other tests done in order to attain a secondary outcome. They were to assess secondary outcomes. They were audiometry, tympanometry, basically safety tests to see whether drug was safe or not, and to monitor adverse effects. Other blood tests like baseline hematological tests, C-reactive protein, and kidney and liver function tests. And importantly, their sputum was analyzed, sputum microbiology was done along with analysis of serum and sputum for cytokines. So adherence was with the study drug was assessed by the count of the returned study drugs and the participant or the parent report. So parent was, there was a proxy pro forma filled by the parents of younger children, so predominantly in the group from 7 to 12 years. So all the adverse events from the first administration of study drug to the final study visit or withdrawal from the study were recorded. Patients were withdrawn during the study if they had met the safety-related exclusion criteria, lost to follow-up, withdrew consent, had poor compliance, developed infection with NTM, non-tuberculous mycobacteria, used any prohibited medications, or reported serious or intolerable adverse reactions. And following this procedure, there were two outcomes as predetermined. Firstly was the primary outcome. So primary outcome was to assess the number of respiratory exacerbations over 6 months. So basically, they defined a respiratory exacerbation as any respiratory tract symptoms leading to initiation of systemic antibiotics, irrespective of any culture reports, or a decline in the predicted FEV1 by 10 points or more, whether antibiotics were given or not. So two things were included in the definition of exacerbation according to the authors of the study. Firstly was whether they received systemic antibiotics, and second was a drop in FEV1 by greater than 10%. So coming to secondary outcomes, there was the first, there were 5 broad classifications of secondary outcome. Firstly, changes in PFT, pulmonary function testing, such as FEV1, FVC, or FEF 25 to 75, residual volume, ratio of residual volume to total lung capacity, as well as airway resistance and lung clearance and related indices. So along with PFT, they also used nitrogen breath washout indices such as lung clearance index. Secondly, they used a validated questionnaire, which was called the quality of life PCD questionnaire, which had, among other symptoms, it also included mainly 3 classification of symptoms, which was filled by the patient or the parent in case of children. So it was respiratory symptoms, sinus symptoms, and ear and hearing symptoms. And thirdly, the secondary outcomes in labs, basically changes over 6 months, mainly for safety, was audiometry and tympanograms. and some inflammatory markers. Fourthly, for sputum microbiology, the number of pathogenic airway bacterial species and resistance to macrolides was also assessed. And finally, it was a phase 3 clinical trial, so it was very important to assess the adverse events, especially the serious adverse events. So coming to statistical analysis. So firstly, the sample size estimated by them was 50 patients per group. To detect basically a 50% reduction in the rate of exacerbations in the azithromycin group, they had to recruit 50 patients. And this was assuming that each child or each patient in the placebo group had at least 2.5 exacerbations per year. They assumed a 90% power, which means to say that they were 90% sure, they had to be 90% sure they would catch the real effect of the drug on reduction of exacerbations, with an alpha confidence interval of 0.05, which is 5%, which means to say that at least like only 5% of the time the results would be significant just out of luck. So estimating a 20% dropout rate, 125 patients had to be randomly assigned. So this was important because this could not be, this was one of the only limitations of the study where the sample size could not be completely recruited. So intention analysis was based on the intention to treat, that is, all the patients who were enrolled in the study were analyzed and defined as all the patients randomly assigned to the treatment, except for certain secondary outcomes that, especially importantly, sputum microbiology. They were based on a their analysis was based on a modified intention to treat, because only the patients with relevant follow-up visits were included in the analysis for importantly sputum microbiology. So the rate of detected pathogenic bacterial species in the sputum in the two groups was compared using a negative binomial distribution. So this was as another supplementary analysis. They had also used the probability of remaining free of exacerbations and the probability of dropping out were determined using the Kaplan-Meier method, so which we'll be seeing in the coming results.
Vishal, you are not heard.
Yeah, Dr. Vishal, you are not heard. Please unmute. Dr. Vishal, please unmute. Yeah.
Am I heard now, sir?
Yeah, yes. Now you're okay.
So coming to the flow diagram, 102 patients were enrolled and screened, 12 were excluded, 4 did not meet the inclusion criteria, and 8 withdrew from randomization, and around 90 were randomized. Out of 90 randomized, 49 were assigned to azithromycin and 41 were assigned to the placebo group. Out of 49 assigned to azithromycin group, 47 received the intervention because 2 did not withdrew their consent. And out of 41 assigned to the placebo group, 41, all of them received the intervention. Following this, 47 who received intervention in the azithromycin group, in the follow-up visits, 2 had no follow-up visit. Another 5 withdrew, and around 40 of the azithromycin group had completed the study. Whereas in the placebo group, 4 again had no follow-up, 2 withdrew from the follow-up visits, and 1 withdrew at the 6-month follow-up visit, and hence only 34 completed the study. So the total number of patients who completed the study were 40 in the azithromycin group and 34 in the placebo group. So the study was published in 2020, but study was performed from June 24, 2014 to 2016, and last follow-up was during May 2017. So the study ended without having included the set number of patients because of recruitment difficulties. This was despite a prolonged recruitment period, and also because there was a lack of funding for further extension. So coming to placebo, basic baseline characteristics. So we've just color coded this into blue and green. So firstly, these are just the baseline characteristics, which were one of the advantages or one of the strengths of the study, were that the baseline characteristics were well balanced, in that the azithromycin placebo group had similar characteristics. So it is important to know that RAW, which is basically airway resistance, which is assessed. Airway resistance was slightly more in the children with who were receiving the placebo group. This was prior to them receiving placebo, obviously, and it was slightly higher in them. And also the quality of life PCD scale scores were was slightly higher in the azithromycin group for the respiratory symptoms. And as you can see, for the children whose parents had given the parent proxy filled questionnaire, the placebo receiving children had slightly higher scores. So other than this, the baseline characteristics, including the gender distribution, the age-wise distribution, as well as baseline clinical data, as well as pulmonary function testing, nitrogen washout indices, as well as other secondary outcome measures like hearing, hematological parameters, were all by and large well balanced between the two groups, which added to the strength of the study. So coming to the first main outcome, which was to see whether the exacerbations were reduced. So 87 events were fulfilled per protocol as defined respiratory exacerbation, out of which 31 children in the azithromycin group had exacerbation, 56 in the placebo group. So the mean of respiratory exacerbations of 6 months was found to be 0.75 in the azithromycin group, compared to 1.62 in the placebo group. And a patient receiving azithromycin had significantly lower rate of exacerbations during the treatment period, with a significant p-value, compared with those receiving the placebo. So this comes to show that the drug had an effect in reducing the exacerbation, given the significant value. And the treatment groups had very similar baseline data, except, like previously mentioned, a lower percentage predicted mean airway resistance in the azithromycin group than the placebo group, higher mean respiratory scores in the quality of life in the azithromycin group, and lower parent proxy scores on certain on the sinus and ear and hearing symptoms in the azithromycin group. So this was just the only difference between the two groups when it comes to baseline characteristics. So coming to the cumulative number of respiratory exacerbations, as we can see, the above graph shows the placebo group, where there is slightly the percentage of patients and the number of exacerbations was slightly higher. And coming to the azithromycin group, it was significantly lower. So the probability of remaining free from respiratory exacerbations was found to be 57% in the azithromycin group, compared with 30% in the placebo group at 180 days of the follow-up. That is around 6 months of the follow-up. And so the probability of remaining free from exacerbations during follow-up clearly favored azithromycin group. So this graph, basically, this is a Kaplan-Meier curve. And this compares the two groups, which is azithromycin and placebo. Here, the y-axis is the probability of no exacerbation, whereas the x-axis is basically the time in days up to 6 months. So the curves, the red curve is the azithromycin group, the blue curve is the placebo group. And basically, some key observations in this graph is that the red curve remained consistently higher than the blue one, which suggests that there was a higher percentage of patients in the azithromycin group who remained exacerbation free as compared to the placebo group. Secondly, you can see that there is a separation of the two groups over time, which means to say that the difference between becomes more and more obvious as the days go by. So by the time the 45 days of the trial had been done, the difference between the two groups was starting to become more and more significant, which suggests that there is a likely beneficial effect of azithromycin. And the small vertical lines are areas where the patients might have dropped out. So that, along with the primary outcome, the other certain secondary outcomes, firstly with PFT, in this study, the change in the predicted FEV1 over 6 months did not differ between the two groups, and there was no between group variant differences found also in FVC and other indices like plethysmography and ventilation inhomogeneity indices, like nitrogen washout indices, that is. Secondly, the quality of life PCD questionnaire, again, even in this study, which found there was no statistically significant between group differences seen in the three pre-specified endpoints of, that is the respiratory symptoms, sinus symptoms, and ear and hearing symptoms. Changes in again other things like hearing outcomes and inflammatory markers also did not differ. So this, just to summarize, that the secondary outcomes, they could not find a significant difference between the two groups when it came to PFT, nitrogen rest washout, body plethysmography, or quality of life PCD questionnaire. This could be likely because the study was done for only a duration of 6 months, and probably if a study was done for a longer time, like a year or longer, then they could probably see some kind of variation in the PFT and the other parameters. So coming to one of the other important secondary outcomes which they found, out of which 224 sputum cultures were analyzed, out of which 90 were positive for bacteria, pathogenic bacteria, and out of which 75 of these were tested for macrolide susceptibility. And it is important to note that the mean number of pathogenic bacteria was 0.93 in the azithromycin group, whereas it was 2.41 in the placebo group, which shows again a significant difference in the number of bacteria which are seen in the children. So it was significantly lower in the azithromycin group when compared to the placebo group. So again, 26 out of the 45 children had no pathogenic bacteria in the azithromycin group over the treatment period, and 8 out of 37 participants in the placebo group had no bacteria, which is a 58% compared to 22%. So this was just an analysis of what bacteria they had found. So usually tested for found Haemophilus influenza, pneumococcus, moraxilla, staph, that is MRSA, as well as macrolide resistant staph, pseudomonas, as well as stenotrophomonas. This was done at baseline, 6 months, and anytime in between the treatment period if there's any emergence of any culture positivity. So as a clinical trial phase 3, it was important for them to analyze the adverse effects, and serious adverse effects were reported in 4 participants. That is, the 2 participants, one from each group, was admitted for respiratory exacerbation requiring IV antibiotics, whereas one participant from the placebo group was otherwise admitted for some upper abdominal pain, which didn't require any treatment. Another was an older female patient who was admitted for an ovarian cyst, which turned out to be a teratoma. So adverse events was reported by around 79% of the azithromycin group, whereas 76% of the placebo group. And the most commonly reported side effect was diarrhea in the azithromycin group compared to the placebo group. And there were other side effects, like some of them had self-reported auditory complaints. So there were other side effects like ALT increase, and some had mild to moderate eosinophilia, but it was very minimal. As well as important one was that there was no significant between group differences seen in the emergence of macrolide resistant pathogenic airway bacteria. So this was important because it was given for a period of 6 months, and there was no significant differences in the azithromycin group and placebo group when it came to emergence of any resistance to the drug. So at the end of this trial, what proved to be very make this trial stand out was it was one of the first ever multinational RCT in primary ciliary dyskinesia. And firstly was that the primary outcome, what they set out for, they achieved in that azithromycin maintenance for 6 months significantly reduced the number of respiratory exacerbations to half in comparison to the placebo. And also basically by reducing the exacerbations, they hypothesized that it is going to also prevent irreversible declining in the lung function, and also reduces the need for additional antibiotic treatments by reducing the number of exacerbations. So in this study, the secondary outcome, there was no significant differences in the lung function. Just to give a comparison with other studies, there were 6-month and 12-month studies done in different types of groups of patients. That is, there were 2 placebo-controlled trials investigating azithromycin in adult patients with non-CF bronchiectasis. That is, for example, non-CF bronchiectasis, including PCD, and in children with cystic fibrosis who are not infected with Pseudomonas aeruginosa. So why these 2 particular groups they were studied? They found that there was no significant difference in the FEV1 or FVC ratio. They had done studies on children with cystic fibrosis with infection with Pseudomonas aeruginosa, and azithromycin therapy in them obviously was found to be beneficial and showed a improvement in FEV1. So more importantly, a 12-month study was done, which showed a significant relative increase in FEV1 and percentage of predicted FVC seen in adult non-CF bronchiectasis patient. One of these patients had PCD, but it was just to show a comparison that there were studies done using azithromycin in non-CF bronchiectasis in older patients as well as in children. So what this study says that is that there is a longer intervention period might be required to significantly change the lung function in patients with PCD, because the annual decline in lung function after diagnosis is on average of limited size. So secondly, other multiple breath washout indices, including lung compliance index, they found that there was no significant difference. There have been studies which have been done which show mild to severe ventilation inhomogeneity between in older patients, and a significant increase in lung clearance index in children and young adults has been demonstrated over a 1-year period. So lung clearance index is an index which is assessed using nitrogen breath washout. Nitrogen is inhaled, followed by inhalation of 100% oxygen, and following this, a measurement of the percentage of remaining nitrogen is calculated, and a higher lung clearance index is suggestive of a poorer vital capacity of the lung. So they have found that a significant increase in lung clearance index in children and young adults has been seen. And in adult non-CF patients, a placebo-controlled trial was done with 6 months azithromycin, which did not show any significant improvement in quality of life. So again, this study also did not show any significant improvement in the questionnaire, quality of life PCD questionnaire following the azithromycin therapy. Again, because probably the children had higher baseline scores, as well as secondly that the questionnaires were filled by the parents, so it was a proxy questionnaire, so that could also be aiding to this. So other adverse effects was that GI complaints only rarely led to discontinuation of the study or withdrawal of the drug. There was no significant increased frequency of hearing loss, and only few reported any hearing symptoms. So the present study confirmed that macrolide susceptibility testing of airway should be done, and because they found that there was a significant reduction of more than 50% of the PCD patients receiving azithromycin. So screening, and also they have proposed that screening and post-treatment testing for NTM is done mainly because there's speculation that the long-term azithromycin might predispose children to infection with the non-tuberculous mycobacteria, and that was one of their inferences. Coming to the strengths as given by the authors, one is that it was like comprehensively blinded study, multi-center and a controlled design. There was a large sample size for a trial in this relatively rare disease. It was the first clinical trial in PCD which confirmed the hypothesis on the treatment of the disease. That is, they set out a primary outcome, and they accomplished it by showing a significant change. And they also did some safety testing by examining the hearing level by audiometry. And also, a high percentage of airway bacteria was tested for macrolide susceptibility, given that you're giving a longer duration of antibiotic. So coming to limitations given by the authors, they were unable to include this planned number of participants. What they said was there was a wide range, including pediatric and adult patients, necessary for the rarity of the disease. Although it was a multinational setup, they could not attain the set number of patients. There was no definition of exacerbations in PCD during that point of time, and whereas in the 2019, where the study was in 2014 to 16, and 2019 there was a consensus guideline published in the ERS journal, which says that there is a particular definition for PCD, where one of six, if 3 out of 6 symptoms like
Vishal, go a
yes,
little fast. We should have some time left for discussion as well.
okay, sir. So coming to critical analysis, there were we used two particular checklists to analyze this RCT. Firstly was a Concert 2025 checklist, which is an updated version of the 2010 checklist. So they fulfilled almost everything on the given checklist. Title and abstract was clear, except that it was not double-blinded because all of them were blinded. So it is a comprehensively blinded study, and it should have been mentioned in the title that blinding was done for the caregiver as well as the recipient, instead of giving the term double blind. So it was a registered trial. Protocol is accessible on the given website, and there was no the funders were listed, and there was no type of discrepancies. It was a strong background, and objectives are clearly mentioned. Trial design they have given, it's a multi-center double-blinded parallel group RCT with phase 3. Inclusion and exclusion criteria clearly defined. Locations were specified where the studies were conducted. Interventions was again defined when and what dose of the drug was given. Outcomes, again, primary and secondary outcomes were very clearly specified. However, one probably critic could be that the parental symptom diaries used introduced subjectivity into the analysis. So sample size was calculated, and estimated sample size could not be recruited. Randomization, again, block randomization, external consultancy using a database, web-based data system, and it was a comprehensively blinded study. Results, there was a participant flow diagram which was provided. Recruitment, how they recruited, who dropped out was detailed. Baseline data was well balanced. Outcomes, primary outcome was achieved. Adverse events were all well analyzed, including serious adverse events. And coming to the discussion, results interpreted in light of prior evidence and limitations of their own study was acknowledged. So this is the new Concert 2025 checklist, which you have just covered in the past 4 slides. So why we used another analysis is why we used the Cochrane risk of bias tool was because it is like Concert only mentions about the reporting quality, whereas that is you're just everything which comes, everything which gets ticked on a Concert doesn't mean that the study is a very high quality study. It means to say that it is fulfilling all the required criteria. It only tells whether the trial includes all of details such as randomization, blinding, but it doesn't really assess whether these things were well done. So what assesses is basically complementary to Concert is a checklist called as Cochrane risk of bias, which basically assesses methodological quality. So coming to this, there are 6 parameters: bias arising from randomization process. So there are 3: low risk, some concerns, and high risk. As you can see, there were 6 criteria. One was randomization process, intended interventions, missing outcome data, measurement of the outcome, selection of the reported result, and overall risk of bias. As you can see, out of the 5, only one, that is the reported result, could have had some concerns because the protocol amendment to the primary outcome was removed, and there was overall risk of bias was still low risk, which means to say that it is complementing what is found in the Concert checklist, that it is a very good quality of randomized control trial. So in conclusion, I would like to say that this first step towards evidence-based pharmacotherapy for PCD and azithromycin maintenance therapy for 6 months, half the exacerbations in patients with PCD. Along with this, they found that pathogenic bacterial species decreased with giving PCD. It gives rise to speculation that starting therapy in infancy with a view to prevent the development of structural damage and bronchiectasis, along with the given that the side effects were minimal, is should be on everyone's mind while treating a child with PCD.
Thank you, Dr. Vishal. Can you stop your screen share? Okay. That was a very extensive analysis of the article and was very well done by you. I thought there were certain concerns in the study before I hand over it to Dr. Matthews. First of all, I thought the clinical data of the patients, like neither were the CT scans reported which of the patients already had bronchiectasis or did not have bronchiectasis. That was a very good big concern about this study. to analyze and understand whether why were the in which group the exacerbations were more or they were not more in the placebo group versus the group of patients with PCD. The other thing is that the number of pediatric patients in this study were very, very small. There were hardly 15 patients, I think, if I remember correctly, in the placebo group and similar amount in the azithromycin group. So how much can we extrapolate data? The third concern that I thought was, of course, azithromycin is being used and you showed low resistance, that the microbiological flora which they identified was less of Pseudomonas and more of H. influenzae, Streptococcus, Staphylococcus, where we were to compare it with cystic fibrosis, where the main reason for usage of azithromycin is basically for Pseudomonas, for a variety of reasons. For the fact that we have less time, I'm not going to go into all the reasons why we use azithromycin there. So I thought that now, and of course, which you mentioned as a limitation, that it was a 6-month-long study, we cannot really document a change in lung function. So their secondary outcome was a problem in 6 months, FEV1 alteration is less likely to be seen or witnessed or to be demonstrated. So I think these were big concerns for us to extrapolate data and say that azithromycin, we need more studies I understand it's a rare disease. The number of cases recruited was small and could not be recruited more, even though it was a multicentric study, and therefore they had to, change their age limit, etc. Over to you, Dr. Matthews, before I can take up lots of comments on the chat box.
Yeah, thank you, madam. I think he has presented very comprehensively and also shown us a critical appraisal. Since time is running out, I have no additional comments to make, except the study is well designed, did not meet the required sample size, and some tweaks were made, but otherwise overall qualifies for a properly done RCT. The rest will take up when the questions begin. Thank you.
The questions in the chat box.
Ma'am, take opinion from Dr. Lodha, sir, also.
Yes, I will first take opinion from Dr. Lodha. Dr. Lodha, are you there?
Yeah, thank you.
Please.
So, yeah, Dr. Vishal very well presented. I think explained the study and everything very clearly. Just like to highlight a couple of things. So, for critical appraisal, we do not use the reporting guidelines. Any article when you're submitting, based on the study design, you will choose a particular reporting checklist, and that's not really the tool to do critical appraisal. In the chat box, I've shared one of the resources where critical appraisal tools for various study designs are mentioned. So that's more appropriate kind of setting. Second is the issue about, I think, blinding. I think we should be clear. I think double blind is good enough. I don't think so there's any terminology like, comprehensive blinding which would be used. It's just a method of describing. Here, obviously, the age group is, beyond the pediatric age group. Therefore, you would have patients themselves directly being taken care of, as well as, children and adolescents would be there. And I guess if we don't have that breakup of how many were less than 18, but less than 21 were almost about 2/3 of the patients. So that kind of gives a reasonable thing. We kind of take pediatric age group up to 18. Many of the Western countries take it up to 21. So I guess a fair proportion of children were actually, a fair proportion of participants were actually children. Certainly the interest in azithromycin has been there in a way. One could argue that, when you use these just 2 weight bands, that's a cutoff of 40 kgs to decide the doses. There's a fair bit of variability in the per kg dosing which may happen. And therefore there would be concern, but then there would be issues around, like again, ease of administration. And maybe if you were doing it in children alone, you possibly may have chosen a liquid formulation, and you could have dosed more accurately based on, their actual weight. But then I think in trials, when you're doing multinational or, the multi-site kind of thing, you also need to look at the feasibility and to what extent it would be there. So it would give you a fairly safe kind of range, which may be there in terms of the dosing profile. But if suppose there was a dose response kind of a relationship, then there could be a fair bit of variability in per kg dosing that would happen, particularly in the pediatric age group. So we need to keep that in mind. Just a few general comments. So one is obviously your primary outcome is something of interest, which is an exacerbation. One could argue that they defined it rather loosely because, initially they said that it would be a physician or a investigator or another physician treated exacerbation, but then they took any antibiotic administration, which means, the parents or caregivers could also have administered. So makes it a little bit loose. As far as possible in trials or other things, if you're looking at outcomes, one could choose a standard definition rather than, creating one. But as the authors have highlighted that there wasn't any specific standard definition at that time point, so they used this. Subsequently, there are some, society guidelines which may be providing that information. So just a general thing, and one would generally limit the secondary outcomes to a few, a handful. Here you have n number of secondary outcomes, which may be, trying to get too much out from this. So I think if for fellows and all, if you're designing studies, it's good to just keep a few, 2, 3, 4 appropriate outcomes rather than trying to study anything and everything. Makes it a little bit more complex when you look at the data. They've used a fairly complicated method of statistics. Again, I think partly driven by the numbers that they're handling and the kind of distributions they would have got. But the main outcome is basically number of exacerbations, and one of the important factors may be what was their baseline exacerbation rate. To an extent, that would determine what may be happening. And I don't think I saw that information very clearly that a certain number is there, because if somebody is already predisposed to more exacerbations, and if there's an imbalance, you could say randomization, but then this is I would say, reasonably small sample size. And partly we can see that even though they had block randomization, which is partly done to ensure balancing between the two groups, there's a fair bit of difference between the two arms in terms of number of participants that have been randomized. So these are some of the, let's say, other aspects that one just needs to keep in mind. But I must congratulate Dr. Vishal for a very clear and a comprehensive presentation. Thank you.
Thank you, Dr. Luda. I'll just take the question in the chat box here. Why was the FEV1 below 40% taken as an exclusion criteria? Hello?
Unmute yourself, Vishal.
Any comments on that?
1 second.
So the FE1 was one of the criteria for inclusion in this study. The reason being that they have selected those patients with lesser the FE1, more sicker they are, may cause more bias to the study.
Yeah.
I heard all comments from the experts. I had a couple of comments to make here, like,
I will give you the chance to after we finish the question.
Sure.
Vishal answer the question.
Ma'am, am I audible, ma'am?
Yeah, you're
Yeah,
audible.
you're audible.
Yeah. The other comment was infection.
Just Dr. Indu, can I just add? I think when we talk about excluding sicker patients, I don't think so. It's about bias in a setting, because they could have possibly, if one had to include, they would get into two arms. I think whenever you're doing trial and first of the kind trial, and you're not very sure about what the effects or the side effects would be, generally one would tend to leave out the more sick patients. That's a general principle that one would follow for trials which are still, even though it's a phase 3 trial, there isn't much data available overall in this kind of a setting. So I think just from that purpose, one would often exclude more sick patients in trials.
And I think for a similar reason, they excluded patients who had active infection with Pseudomonas and Molcharia. They would rather treat them rather than put them in a trial.
They excluded those with chronic infection, ma'am. Also, that was one of the points I brought about, that why azithromycin is given was chronic Pseudomonas Pseudomonas infected patients were excluded from the study.
One more question was, how did they obtain the sputum sample in children for the microbiology?
It was not available in the details given to this.
And how did they differentiate it from common cells?
That again, they're not mentioned in their methodology.
Okay. Any age cutoff recommended, duration? I don't think this was all mentioned in this study.
They have just mentioned that ideally they should give it for, they can give it for a longer time, given that side effects were slightly lesser.
One more question that the quality of life questionnaire which they have used was more
Yes.
adult specific and rather than pediatric specific, and I think that was
Yes, it is like likely to be more adult specific, but there is there are either other than physical symptoms, there are psychosocial questions also, and usually that's difficult to be filled for pediatric patients by the parents.
Again, this I think has already been answered, mentioned by Dr. Loda. What is the definition of a pulmonary exacerbation in this study? Would you want to highlight that again?
Yes, ma'am. Actually, they have mentioned in the study that there are exacerbation is those children requiring systemic antibiotics or a drop in FEV1 greater than 10%. They only utilize these two parameters, and this was because the study was done at a time where there was no fixed definition of exacerbation. Whereas in 2019, there was a published consensus in ERS which suggests that symptoms like a chronic cough, second symptom being malaise, there were six parameters, out of which 3 out of 6, if they are positive, that could include that would be included in a definition of pulmonary exacerbation in PCD.
One more thing about the study was the number of exacerbations they when they used the exclusion criteria and the inclusion criteria, they talked about 30 days use of antibiotics in the last 2 years. So they were barely talking about 1 to 2 exacerbations, and then they used azithromycin to see how much the risk of exacerbation. Do you think that was a good enough criteria to use, or was it really very, like you already are talking about just 1 or 2 exacerbations in a year, and then you're using azithromycin to demonstrate a decrease in the exacerbations?
Yes, I mean, initially to start the study, it probably wouldn't have been significant, but given the result that those in the placebo group still had a higher rate of exacerbations given compared to the azithromycin group, so their end probably justified that the use of azithromycin brought down those exacerbations whichever were there.
Dr. Parmat, your comments, please.
Yeah. So thank you, everyone. Vishal, well presented. This was a well-designed study. See, this is a PCD is a rare disorder. All of us know this. How much patients will get in each arm to a conclusion is also difficult. Despite having best of the resources, they could not have the enough sample size to complete the study. So we in India probably have not done any trial on PCDs as yet in any of the drug or any that's in pediatric, though hardly any I see. There is another trial which is currently ongoing, which is based in Australia. They have started the trial in 2022 that is called as a repeat trial. That is based about azithromycin in PCD patients with a novel mucolytic agent which they are going to use, that is erdostin. Okay, so they are going to study this, and again they have a sample size of 125 patients. Probably will have, this is a basic exclusive pediatric trial because there was a question about adult population. In this trial also, which we have seen basically around 35 patients were in less than 21 years of age group. So which is fair enough. Like researchers have tried to complete the trial in few this thing, but what I feel is one of the primary takeaways which they did not find in this study is the lung function improvement, which they did not find. Okay, what is only positive about this study is prevention of exacerbation that they could find, because probably one of the limitation being the dropout rates, second thing being the duration of the study as well. Okay, and they could not continue the study for a longer duration to come to another better outcomes. But that is what the trial is about. Another thing is this study, the patient's age was from 7 years onwards. Nowadays, we are seeing PCD, we are diagnosing PCDs in neonatal age groups as well. So what has happened over next like 7 years, the lung damage which has happened because of late diagnosis, not using of azithromycin. So we are seeing these patients much earlier. So probably this opens another window for our research also. If we start azithromycin much earlier, based on the patient's age group, like what we are using for cystic fibrosis, maybe we'll have different outcomes over a period of time. So this is a trial which probably has given us some insight into PCD, and we have our open mind to take a call upon whether to use azithromycin in PCD patients, which we are diagnosing at much earlier age. So that is my comment, and that is my positive take from this article.
Thank you, Dr. Parmat. I had a comment here. So though we are using azithromycin in children with cystic fibrosis, we are using it for multiple reasons. I did not highlight it more for anti-inflammatory and Pseudomonas, but the microbiological bugs that are there in PCD are still not similar to cystic fibrosis. Though you may have Pseudomonas or you may have, but generally you also find other microbiological flora. So how much we will need to do a study to know whether we can actually start azithromycin earlier in children with PCD. We will need to have more data. We have to be worried about even the antimicrobial resistance that will occur, because there is a difference. Even if you look at the inflammatory markers in, say, in cystic fibrosis, there are a lot of studies on the inflammatory markers which they have studied for CF. So there is some more data there and less in PCD. How much is the inflammation? There are a few studies on that too. So using of azithromycin for inflammation, using it for Pseudomonas, I think we need more definition in PCD, and that is a limitation we all face because of this rare disease. Dr. Loda, would you like to give a comment and a take-home message for use of?
I think, I guess I don't think one would really modify or start using azithromycin routinely in any age group at this time point, unless there's another indication. This is a fairly small study. We certainly don't have any data below 7 years of age. And therefore, I don't think we should be taking home the message that azithromycin is beneficial in this kind of a setting because of multiple issues. A single study, maybe if other studies kind of give some data, and we need to understand the differences between, as you highlighted, CF and PCD. The lung function in PCD may not be declining as fast, provided other things are being done. And therefore, I guess that still should be the mainstay of the management as of now. Maybe if there's a PCD and develops bronchiectasis and so on, and has so even there it would be more like a expert view rather than actually evidence-based practice. If you're looking at this particular article, even though it's a trial, it's a blinded trial, many positive things, few limitations, but I don't think so this is enough to modify practice, and certainly not for the age group where it has not been studied. I don't think so we can extrapolate that if there's some gain here and therefore there would be greater gain in if we start early. I don't think we based on the evidence alone, right? I don't think so, but certainly sets the stage for people to look at it in a trial format. But even in that setting, one would need to look at what benefit one is likely to see. So if we know that if during a particular page or so, and the kids are not too symptomatic, or they are mainly upper tract and so on, maybe one would have to choose where the impact is likely to be seen. And the lung function change, again, we would need to see carefully. And as compared to CF, obviously the lung function may not be changing at it wouldn't be declining in a similar manner. Therefore, doing it over 3 months, 6 months, or even a year's period may not be enough to look at any kind of effect which may be meaningful. Yeah, thank you.
Thank you so much, Dr. Rawat. Would you like to make a comment before we close?
Thank you very much. And Dr. Vishal, you have presented excellently. I think this study has at least opened a window, because doing studies on PCDs, it is a difficult. Number of cases are very few. At least they have opened a window where they have shown that azithromycin can decrease the incidence of exacerbation by about 50%. At least we have got some data. Definitely, I agree with Dr. Loda that we cannot extrapolate this data for children and below 7 years. Probably we'll need more data, but the positive thing is that at least there is some window of data that azithromycin can be useful in children with PCD. So let us hope that we get more data and that we can use it more confidently in children below 7 years. Thank you very much.
Dr. Ajay Kumar, thank you so much. Anything you would like to say before we wind up?
No, ma'am, I like to thank our presenter, Vishal and Dr. Chandane, session mentor, as well as Dr. Lodha sir for giving the time and so beautiful comment on this setup. And thank you, ma'am, all of you, Dr. Rawat sir, Dr. Aap, Dr. Indu ma'am, and Dr. Joseph sir, and other EB member who are present in this scheme. So, thank you, ma'am.
Thank you very much, everyone.
Okay,
Thank you very much. Good night all.
Bye.
Good night.
Good night.
Good night, ma'am.
Good night, sir.
Good night, sir.